We've got some risk factors from a work perspective. So you might have the patient that doesn't get up and move around from their desk for 3 hours. And then they work through their lunch break and they have their lunch thing at their desk. And they do that all again throughout the day. That's a real problem. And that's a problem from just a general health perspective. You want to be kind of getting your patients moving up about every kind of 45 minutes, at least every hour. Heavy work, so load-bearing stuff, repetitive arm movements, arms up here. I think trades is a real challenge to rehab, and really crappy pacing is another big one. So that would be an example of just sitting at your desk and not moving. And for any tendinopathy, it's the usuals. It's the usual suspects: overweight, obesity, all that stuff. So if your patient comes in and they're not super healthy, you probably want to start to address some of those lifestyle things as well. You can give them the education. Look, we know that these things are going to be influencing the health of your tendon and the health of your shoulder. So painful arc we've been through. Have you done, you said Hawkins-Kennedy you've done? Yep. Okay, let's have a little bit of a gander. This is your test cluster.
Find more time for storytelling with CGU's time-saving business tools.
This is going to be a video on the Hawkins-Kennedy test for shoulder impingement.
PhysioTutors is an excellent website, by the way, YouTube channel.
Hi, and welcome back to PhysioTutors. The Hawkins-Kennedy test is a commonly used test in the assessment of shoulder impingement. According to a big study done by Hadjidas et al. In the year 2012, the sensitivity is at 80% and its specificity is rated at 56%. To perform the Hawkins-Kennedy test, have your patient in sitting position. Elevate the arm to 90 degrees of forward flexion and have it rest on one of your arms. Then perform passive internal rotation. A positive test is the provocation of pain. If your patient has pain during the test,
often your patients, you don't even need to do that test because they're already super irritable. They've already got a painful arc. You don't need to do it, it's redundant. But it's still good to learn, and particularly for those ones that you really need to hunt for. So you're just compressing the anterior structures of the shoulder. There's a lot there. You can't say, yes, that's supraspinatus, or yes, this is the bursa, or there's too much stuff going on there for you to go, okay, this is a definite pathology in this structure. Can't do it. Knees test.
this is going to be a big test for shoulder impingement. Hey everyone, the NEAR test is another very common test used in the assessment of shoulder impingement. According to a big study by Hadjidas et al. From the year 2012, its sensitivity is 72% and the specificity is rated at 60%. To conduct the NEAR test, have your patient in a sitting position. With one hand, depress the scapula, and with the other hand, internally rotate the patient's arm, and then perform maximally forced forward flexion in the glenohumeral joint.
I mean, it's not very nice even if you don't
The
have
test
shoulder
is pain
pain, to be
reproduction.
honest. So that's another one we can use in the cluster. So empty can, same thing. If they're weak, if it's eliciting pain, that's going to be part of at least your 3-test cluster. And pain in external rotation, internal rotation, or just super weak, which for an irritable shoulder, usually you'll do that and you're like, and they just can't give you anything, particularly with internal rotation. One of the things that I think is really cool to know, if people haven't got the reference here, is that they've shown that shoulder pain and disability is not well correlated to cuff tears, size, or location, which is a pretty surprising thing. Think about your rotator cuff, it's a super redundant system. You've got all of these other muscles around to help out. So if your patient comes in with a scan saying, oh, this is bad, I've got a full thickness tear through here, I definitely can't move my arm, and they're really fearful, you need to start to do some education there, because that is not the case at all. Even if you've got full thickness tear through supraspinatus, you can still get full range, you can still be fine, because you can strengthen all of the other muscles in that area and still have a really well-performing shoulder. We're not going to go, we don't have time today to go through the special test clusters for SLAP lesion and ACJ, but we will play around with some of them in the tubes. But we're rapidly running out of time. So keep home, go practice. Practice, 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 practice. And if you're coming to higher function for your prac, hopefully you'll know them. Okay, so treatment. So we don't actually know how exercise works, but it does, or what the best exercises are. So open versus closed chain, different types of loading methods, home versus gym, painful versus non-painful. But essentially you want to go through, for a painful shoulder, usually, particularly if it's tendinopathy, isometrics, then your dynamic, then your eccentric, then your plyo stuff. And that's for any musculoskeletal injury. With a shoulder, it's going to take up to 6 months, depending on the severity of it, and depending how irritable they are. And this all depends on how well they actually comply and do their exercises. And this one's in your notes. So this is just an example. So you might start off with some isometric, external rotation, internal rotation, flexion, extension, wherever they're weak. Pain is allowed to increase slightly during the exercises, up to the 3, but it has to settle down once they stop the exercises within a couple of hours. So you don't want an irritable shoulder, but you need to educate them that a little bit of pain and fatigue is completely normal. So you might do that for a couple of weeks and build the position of the arm. So if abduction is an issue, you might start off here with your isometrics and work up here. You can hold a weight, you can hold a TheraBand. Go for their most painful movement and train that first. Remember, people aren't going to do huge amounts of exercise. Usually 10 to 15 minutes of rehab exercise a day is plenty. If they want to do more, go. Great. So isometrics, progress their range with isometrics. Then you're going to move into isotonics with arms supported. So on the side of the body, on the floor, with a Swiss ball, with their knee, and with some cable stuff. This is where you're going relatively light loads, high repetition. You're working on endurance here. And the big one is load the weakest movements first. And the functional movements you want to be really mindful of. Go for those guys. Then unsupported. This is the fun stuff. This is where you can get really creative. So you can use bands. You want to try and get a combination of movements. This is where we can really differ from physios that are just purely often working on just that one site. Think bigger than that. Think this person in function needs to work on pushing, pulling, lifting. Integrate those movements into your rehab. Train those functional movements, not just I'm going to sit here and do external rotation and then I'm going to move up here. Train these different movements, because this is what your patient does in everyday life, with a focus on the one that they have the most difficulty with. So they might be here for 6 to 8 weeks and you're just progressing their strength here. If they've got a need to then go back to a dynamic component, maybe it's a sport that they're doing or a hobby, then you need to progress that in as well. So a really great software package is Simple Set. It's got over 7,000 exercises on it. It's not ridiculously expensive, but there's millions of different software packages, so this is where all these photos came from. So you can easily program without having to draw stick figures. I think you guys are using Exercise Physiotech, yeah. I don't like this one, it's a little bit better than I used Physiotech for 5 years, but this one's kind of cool. So it's your normal loading stuff. If they're irritable and they come in and you've flared them up or they've flared themselves up, then you just need to back it off, regress it, and then progress from there.
Sorry, Eva.
Yeah.
We were taught because we just did shoulder last week, that
Yeah.
often you have to address the kinetic chain before you
Yep.
progress into loading and stuff
Yep.
like that. So through the core, through step
Yeah.
control
Yeah.
to get appropriate
Yep.
GHJ movement.
Yep.
I'm noticing that a lot of it is just loading. Are you
Yeah.
addressing flexibility beforehand?
Absolutely. So if they're really tight in a structure, so you've got a functional assessment, is what movement do they really find challenging and what movement do they fall apart. You could look at, if they're an athlete, definitely you've got to look at everything, absolutely. So that's your functional assessment, and then you've got your formal assessment. And your formal assessment is where you're looking at strength, endurance, motor control, timing, coordination. And so your formal assessment is going, like you're training for formal assessment stuff, so flexibility, endurance, strength. You use that to go, where does that patient, they're not so good? Does that marry up in their functional deficit? And you're going to be training both. You're trying to get to their functional deficit really soon. So if they are a throwing athlete and their core is rubbish, oh, you would work on that straight away, 100%. Go for the function. That's where these push-pull cross-body movements are so important. But you need to clinically reason and go, well, what do they need and where do they fall apart? And you'll get that information from their functional movement and then your formal assessment of all of the parameters that we've talked about. Does that kind of make sense?
Yeah.
Yep. So yeah, if they're an athlete and you see them throw and they've got no rotational strength through here and it's all just through glenohumeral, massive issue. If they're a kicking athlete and they get pain when they're up here and they're marking and you see them on their stance leg and they're like this, well that's a problem. Train it. Train the deficits that you see. So that's why there's no kind of recipes. It's hard. So these are just, I pulled these ones out as a bit of an example. But you want to be the clinician that can see the whole picture. So for someone who's sitting a lot at work and they're getting pain at work, you say, show me how you sit. How many computer screens have you got? What's your chair? Do you have a sit to stand desk? Like all that stuff. Yeah. Okay, neck pain. Let's do it. So neck pain is a little bit like low back pain, and there are a lot of factors that are going to go into chronic neck pain. There's a whole lot of risk factors there. One of the biggest ones is previous history of neck pain. But there's often some biopsychosocial stuff going on. So you want to look for yellow flags in this population. So any other site stuff, what's their belief of their neck pain, their stress levels, their sleep, all of that stuff. Same with back pain, has a huge effect on sensitisation through the neck. But having said that though, physical features are still really, really relevant. We can't throw out the bio from biopsychosocial. And that's where we can really come into it and do our assessments, just like we've done for other musculoskeletal issues. Okay, so chronic neck pain, always ask about the 5 Ds. If your patient has any of these, refer on straight away. There might be some vascular stuff going on. So refer on. So you just want to just be asking these, put them onto your initial assessment so you don't forget them. Very, very rare. I've not had one in 15 years of clinical practice. So you want to know pain location, referred pain, is it going down into your arm, into your hand? Do you get headaches? Where are they? How long do they last? How irritable they are, so how long their symptoms, if they flare themselves up, how long that pain lasts. Is it a couple of hours or is it days if they have a flare up? So you're looking at their daily pattern. So morning pain, likely inflammatory. If it's mechanical, it's likely with loading. Sleeping position, number and type of pillows. So if the patient comes in, I just don't get comfortable, I have all these different pillows, I bought about 5 pillows. It's a kind of common sign that they're sensitised. They just can't find that comfy position. Ask about their work. If they're sitting, they're doing a sitting job. What's the ergonomics there? A really big one these days is to have more than one computer screen. And if someone has more than one computer screen, really, if they're using a computer screen, say it's 60-40, that's kind of the cutoff. If it's 50%, put them together. The one thing you don't want your patient habitually doing all day is this, looking over to their non-primary screen. So ask them that. And ask them, what side is it? Oh, that's funny, it's the side you've got your paint on. How many times do you think you do that a day? Oh, maybe 300. That's a problem. So ask them about their work habits. Their coping strategies. This is going to give you a sense of, have they relied on passive therapies in the past? So if they say, oh, the only thing that makes it feel better is the physio and heat, and they don't mention any exercise, then you're already thinking, okay, we need a little bit of education here. They've got some passive coping strategies, probably not great. Ask them about their general stress level, their level of weekly exercise, all the normal stuff. You'd ask this for low back pain, ask it for neck pain as well. Okay, questionnaires. This is a really good one. NDI. If you were only ever going to use one questionnaire for neck pain, use the NDI. Insurers love it. So if you've got patients coming under workers' compensation for neck pain, which is massive, a lot with neck and arm pain, NDI every time. Just have it in your file. PSFS, you know how to take that. Patient says, okay, these are 3 things that I'm having problems with, and you ask them out of 10. If 10 is you can do this without any issues, and 0 is I can't do it, and they give you a number. Again, really, really good to keep monitoring even in a non-compensable environment. Okay, subjective assessment. So you want to look at their posture. Do they come in like this? It's a really big one to have that forward head position. Are they coming in, are they really flat through the thoracic spine, or are they really kyphotic? There's one shoulder hanging down here. You want to start to look at these things. Definitely their resting scap position. So a depressed scap you'll often see so it's sitting a lot lower. If you see that, usually it's their dominant arm, and usually they've done a lot of mousing on that side. So that's their dominant arm, and they're usually sitting at their desk all day, and their mouse is out here, and they've done that for 10 years, and they've just got really weak through upper traps. And you'll see a big change in that resting scap position. That's an issue. You want to train that upper trap on that side. Have they got a wing scap? And have they got a tilting scap? So you might go, okay, I'm just going to give you a little bit of elevation assistance to that scap. Does that feel a lot nicer? Does that feel better? So you can manually change that scap position and say, yeah, actually that feels pretty damn good. So you're starting to put it together, okay, that makes them feel a little bit better. Maybe I need to train some up-track stuff. Same with a wing scap. If you just gently tilt it in so it's sitting a little bit more flush on the thorax, does that feel better or worse? This might not change, by the way. You might do this in a way to go, nah. But it's really nice buying if it does, because you go, we just need to get you stronger there. So you can start to play around with manual scap position. This is not a manual therapy session. This is you just assessing. So you're not doing manual therapy. You're just seeing what makes this patient feel better or potentially worse. So we'll play around with that as well in our tubes. Get them to demonstrate their painful movement. This is where the function comes into it. So show me the position that hurts you. Do it now. Let's have a look. Look at their performance in that test. And that's where they might need a little bit of education. Then you'd ask them, well, is there anything that you can do? Like if you're in that position, what makes it feel better? And if they're in this position, which often they are, they're like, oh, you know what? I just constantly want to get up and open my shoulders back and just stretch and move. And you're like, oh God, you just need some exercise and deloading. So you really want to know what makes them feel better. But get them to demonstrate. And if this is an athlete, get them to demonstrate what positions in their sport that it's hurting. if they're a manual labourer or worker, get them to demonstrate. You really, really need this functional movement because that's the one that's important to them. They don't care about all your formal assessments and stuff. All they care about is I want to be able to sit at the computer and do my assignment or do my job without hurting. So really, really important. So you want to look at upper cervical flexion extension, lower lateral flexion and rotation. Have you guys done this yet? The next stuff?
Yes.
Yep. So looked at inclinometer stuff. Yeah, I'm getting some no's.
No, I don't know that we've discriminated upper and lower.
Upper and lower, yeah.
yeah,
Yep.
just
Yep.
generally.
Just general,
Yes.
yeah. Yes. So you guys would have done these just general. These are the normative ranges. This is where you put your inclinometer, and you still need to get that stuff. But often when patients come in like this, and this is a really big one for neck pain, they've just lost that ability to flex in that high craniocervical region. So they are weak through their deep, what we call deep neck flexors that do this nodding movement. And so they'll be sitting like this. And they'll come in, you see them, you didn't see them in the waiting room body, they're like that. So you want to be able to differentiate, can they perform a nod and not flex through that lower cervical region? Can they even do that movement to begin with? You want to look at their flexion control, so that's full normal flexion. When they come back up, they should initiate it from the lower cervical. Extension control. When they take their head back, this is what you don't want to see. What's that? What is happening there? Feel very good. No, it's not comfortable. So we're getting that forward chin poke, and we're really not getting a whole lot of extension up through here. We're just hinging at our low cervical. And you'll often see people back, if you look at the crease in their skin, the back of their neck, you can see where that person's habitually moving. So there's a really big crease down there. You know, they're probably doing the majority of their extension down here. So you don't want to see this. And when they return, you also don't want to see this, just using their SCMs. You want to see them be able to come up into that beautiful upper cervical flexion. And it's easy to assess. I'm getting like blank looks, but you'll see it. One of the things that you want to look at is their ear position. When you go into extension, your ear should go back behind your shoulder. This is not going back behind your shoulder. It's just staying there. So you want to look there. Yep. If they go back and then they just use their SCM to come forward, you'll see really like lots of use here. And they'll still be in that upper cervical extension there. They just can't, they don't have really good deep flexion control. And this is like the core of your neck. You know your TA and your pelvic floor? These deep neck flexors are essentially the same. They're those really deep muscles that are intimately controlling cervical segmental movement, particularly flexion. So rotation, you want to look for restriction. So restriction in the lower cervical spine means that they'll get there and they're like, nah, can't go any further. Restricted upper cervical, they'll go around, but they'll be like this. So their chin will poke out and they're like, oh yeah, I'm there. But they're like that, they're not getting much rotation up high. So you want to start to learn these patterns. Lateral flexion, they can just be really tight. They can be really tight if they're going into left lateral flexion, really tight through scalene potentially, or segmentally restricted. We can't assess that because we can't do physio joint assessments, so don't stress about that. Can you manually assist them to reduce their symptoms? So if they go back into extension, they're like, oh yep, it hurts. And you're like, okay, if I just give you a little bit of support there, so you're just gently cradling under occiput and just under their jaw, and you say, let's go back together, and you give them a bit of assistance, they're like, oh, that's so much better, that doesn't hurt. You know that that's probably not a joint thing, that's probably that their muscles are pretty weak and they just don't have really good control. And if you pretend to be their muscles there and give them the support, they're like, oh, that feels a lot better. That is really good buy-in for going, okay, you just need to get stronger. And it's usually eccentric control of neck flexors is crap. So they're going back and they just don't have good eccentric control here, and they're just slamming back. So then we want to go, okay, we need to start to train flexors, and usually the deep cervical flexors. So a really, really good one, you can do that with rotation as well. So for extension and rotation, you can manually assist. It's not manual therapy, you can do this, guys. You want to have a look at their scap and their thorax control. So if you get them to sit and you ask them to do little small movements about 40 degrees flexion and abduction, they shouldn't get much scap movement. But if you see a winging scap or something happening that's just a bit weird, then at rest they really can't fix that scapular well to their thorax. And if you're sitting all day, that's a real issue. Particularly if you give them, like if you again give them an external rotation movement and you say, okay, just gently push out into me, and their scap's just wing or drop or do something weird, that's not good control. So you want to train scap positioning resting. That is the only time I would train scap positioning, is in those low ranges. In all other ranges, do not try and manipulate your patient's scapula. Don't do it, just let the scapula do what it's going to do. So from all the research has shown that impairments in scap movement, we're really bad at assessing it, we're really bad at working out what's normal and what's not, and there's so much variability. The only time you want to do some scap training down here is when they're below 40 degrees. That's when you'll do your static scap positioning. Okay. Have a look at their thoracic rotation. We did that last time in 4-point. Remember doing that. And their shoulder, like their full shoulder range. So this is, all this stuff is, it's very subjective. And I know that's going to be hard for you guys because a lot of this stuff you can't get numbers on. And that's tough. You've just got to learn, okay, movement patterns. And that takes time. So definitely get your inclinometer out and measure the full ranges. I think that's important because you can then get your number on it. But more importantly, we want to start moving into the functional stuff. Now I know you've used the pressure biofeedback machine for core. You can do it for neck. In fact, I like it a lot more for neck. So you're asking your patient to go into that really nice nod. So upper craniocervical flexion that a lot of people lack because they're weak through their deep neck flexors. So you want to ask your patient to do a nod. Now, this is what you don't want to see. Like all of this come on. So they want to be nice and soft through their primary movers, through their SCM and through their scalenes. You don't want to feel any tension here. So you can lightly palpate and you can get them to go through the stages of 2 millimeters of mercury increments and hold. So usually you want them to be able to do 10 lots of 10 seconds holds. The aim is to get up to that. Usually if someone's really bad at this, they will struggle to even get to 20 and they'll have a lot of overuse of these, or activation of these big primary flexors here. So it's a great one to use. Tough at home because most people don't have one, but you can teach them to do that movement even if they don't have this at home. You can get them, their training can start in supine. You can show them a proper palpation and what's desirable and what's not desirable through the front of the neck there. Okay. So if they're really bad here, don't start doing full-on head lifts and all that stuff yet. You need to optimise their destabilising systems like the back. You know, it's exactly the same as low back stuff. Manual muscle test you can check for, so really easy one to do. Have your patient sit down, you place your hand on the front of their forehead, you get them to do that little chin nod and say push into my hand as hard as you can without using your thorax, so you don't want them to leverage off using their upper body. And then you'll do the same for extension. You can do that for lateral flexion and rotation. So extension should be almost double the strength of flexion. And often people with lots of neck pain, often this ratio will be really skewed. And again, getting a number on it's great. Like if you've got handheld dynamometer, you can get that number and you can show them. You can say, really, you should be up here. Let's just get you stronger. So you're looking for the pattern of movement as well. If you apply a resistance there and they push forward and they do this, weak up here, weak deep neck flexors, they really need to start training that nodding movement. And you want to look at, how much use are they getting through those big primary movers. So at the front, SCM, and at the back, semispinalis. And you'll see semispinalis if you give an extension push and you get a really big contraction there. And you'll see it in some people, it's just massive. That's what you don't want. So we need our deep cervical extensors working, not those big primary movers when we first start training. So we're looking at fatigue, we're looking at, are you getting achy through there? For some people that have headaches, that might actually elicit their headache. That's a good finding. You can say, well, we need to train that. But just remember that number. And it's a really easy, quick test when you start. Isometric neck flexion. So ask them to go into that little nod position, and then they're going to lift their heads up off the bed just a minute amount, like just enough to clear the plinth. And you're going to see how long they can hold for. And can they maintain this without going into chin poke? Note their time. So about 40 seconds for guys, 30 for women. Average for neck pain patients about 20 seconds. You can give your patients those normals and say, well, let's try and optimise them. But you wouldn't start here if they were really crap on deep neck flexors. Start deep neck flexors first, optimise that, then move them to the higher load stuff. Extension test, quite similar. You're going to get them into that nod position and see if they can do an extension movement. How many can they do before they start getting achy, before they start losing form? For someone with a lot of neck pain, often this will be a really jerky kind of movement, going, like their proprioception is really altered. They're like, I just can't get this smooth movement going. The hardest position, so I've moved this through progressions, is here. And we'll do this in the chute. You want to be lying your patient prone on the plinth. They've got their head and their shoulders over the bed, and they're just doing that cervical extension movement, keeping their chin in. You're looking at how many reps they can do. So normal, up to 30 reps. That's quite a lot. When you do this, you're like, oh God, that's a lot. So you're looking as well at their pattern of movement. So for someone who's painful, you're looking for, does this cause pain? How many reps does it take for you to get either want to stop because it's painful or because you're fatigued? And you're looking at their control. If they're losing their control, stop them and just write in your notes, terminated due to loss of control at 10 reps or something like that. Okay. So you're starting to get a bit of an assessment. This is a formal assessment, not functional, about where they're lacking. So when do we know that strength training is indicated? Often your patient will say, oh, like I've got this pain, but my head often feels too heavy for my neck. I get fatigued really quickly by the end of the day. I just feel like I want to go lie down, and lying down feels better. Or they just feel unstable, like something's just not right. If they perform poorly on your formal tests, they're the ones we just went through. Or if they've got signs of that structural muscle changes. So that'll be poor on your formal assessments. And if they feel better after the exercise, and often they will, and that's a really good buy-in for your patient to go, well, that's why we need the exercise. So for craniocervical deficiency, this is not functional, by the way. This is just to get them going, so this is your formal training. So you can start them either with the PVU, they don't need the PVU, they can do this at home, they can go into flexion, palpate to make sure that they're not overactivating big prime movers. Then you can start to add arm movements, leg movements, get them up into tabletop, get them doing their core leg extensions. You can do that nodding in all fours, you can progress it by moving arms and legs and both. At work they can do their isometrics. so they can easily do that at work without it being too embarrassing. The roller is really good for this stuff. You can progress by moving them into like a tilted position, and they can go and do their little nodding there, adding arms. Build your endurance capacity there, at least 10 times 10, or you might come up with something else. You might go 3 times 30 seconds or something. Full flexion strength, that's when you're bringing all of your flexors into it. So then you can start moving into your isometric head lift with good control. You can do that from a tilted position. You can start to use TheraBand, which can be really awkward. A lot of people don't like TheraBand around their head, but you can do it. There's a really good gym meme, has anyone seen, where the guy's got the cable machine over his head. Yeah, don't do that. So full flexion strength, pretty easy to train. Also eccentric strength, so you can have the band there and they have to control going back eccentrically. So I rehabbed a guy that was obsessed with bird watching and he couldn't do it because like you're up there with your binoculars, he needed that eccentric strength. So this is the sort of stuff that we did nice and slow. We ended up getting like a silver band going slowly back and forth, so it's a really good one. And then pure extension strength, this is where you want to get your patient to be able to do 20 to 30 of those really good prone lifts over the bed, but you can start them in regressed positions of all fours and in prone position. That's not functional, so you want to keep in mind what their functional deficit is. So if it's like the guy bird watching, you know that you have to get them back there and you want to get them back there as quickly as you can. So you'll be starting to train just that functional movement even without load. Okay, what time is it? How are we going for time?
Past 11.
Okay, right. We're going to go really quickly. So lateral epicondylalgia. Lateral arm pain over that lateral epicondyle and into your forearm muscles. We're going to 11:30, aren't we? Yeah, 2 hours, yeah. So, used to be called tennis elbow. Do not call it tennis elbow anymore. Don't call it tendonitis. Do away with the itis. Don't do itis, it's not inflammatory. This is the same as all of the other tendon stuff, guys. No inflammatory cells. Changes to the collagen structure of the tendon, and usually extensor carpi radialis brevis. So that's over here. You can feel it if you go into third finger extension. You can feel it moving. Okay, signs and symptoms. So pain and tenderness right over that lateral epicondyle and just a little bit distal and over into the muscle belly of your extensors. Pain can radiate into the forearm and wrist. A really big one is pain with grip. So they've got reduced grip strength and reduced grip endurance. Depending on where your patient's at, depending on how long they've left it before they've sought treatment, usually we move through this level of sensitisation. You get a little bit of pain that kind of goes away, and then you'll get pain at the end or immediately after, then it happens during, and then it happens constantly. If you have a patient that comes in with constant pain, you know that this has been going on for a while and they've probably got a high degree of sensitisation. So we've got more than just what is happening in the tissue. We've probably got changes at the spinal cord level, in the brain, the peripheral nervous system. They might come in with some maladaptive beliefs around their condition, that type of stuff. So this one's a tough one, and usually they've had pain for like at least 6 to 12 months. Okay, 30 to 50 years, no gender difference. No surprise that it's with repetitive use. Lots of typing, mousing, and particularly for those patients, I've seen a lot of it that are doing data entry and they're using the keyboard as the quick thing. So Control-Alt, Control-C, lots of that. So you're going extension plus you're getting some extension through your fingers. So you're getting wrist extension plus this. So lots of overuse. So we know that in manual tasks, handling tools heavier than 1 kilo repetitively handling loads heavier than 20 kilos, and repetitive movements for more than 2 hours a day. And that's a lot of your office workers, which you'll see a lot of in Canberra. So things that will hurt: resisted wrist and finger extension, stretch, they don't like to be stretched, and gripping, that's the big one. And particularly gripping out there. So the longer the lever, the more you compress that tendon, usually the more painful it's going to be. So you'll find patients want to carry stuff in close, and they've just usually avoided gripping. So chopping, that type of stirring can be really provocative. You know, folding and big sheets, that type of stuff, where you've got a grip and you're going into elbow extension. So, palpation, really big one. So if you palpate around that lateral epicondyle and you go down into the muscle belly, it's usually going to be painful. You want to look at their pain-free grip strength. This is not full-on brute grip strength. Get them to grip to the onset of pain, record it. You don't want full grip strength with pain. It has to be pain-free grip strength. And often this might be down to like 1 or 2 kilos in someone who's really provocative, or they just can't even do it. So it's got to be pain-free. We're not going to go through the tests now, we don't have time, but we will in the tute. They're really easy tests to go through. Usually your clinical signs are enough to give it away. Pain on palpation, pain with grip, reduced grip strength is a really big one. If you're seeing a patient under the compensable environment, get some more functional measures. So you can line up some dumbbells and say to the patient, I want you to choose a dumbbell and we're going to do some static holds and see how long you can hold for. So you might have half a kilo up to 2 kilo. They'll select the weight, and then you can get them here or you can get them here and say, okay, we're going to time both sides. When your painful side starts to hurt or you get fatigue, drop it down and I'll record that time, and then you want to compare it to their non-painful side, so that you can go back to the insurer and say, well look, there's a clear, you know, strength and endurance deficit here. Like bearing through wrists, often they really don't like. So that position, push-ups are a nightmare. So you could assess it for the purposes of the insurance company. You could say, okay, let's go onto the wall. If you do a little push-up, tell me if that hurts, to say yes or no. If they say no, that's fine. Okay, let's see how many push-ups you can do. Is that fine? Then move them down to plinth, etc. So you're getting more of a functional outcome. And then for your patient, if they've got a particular thing that's really painful, that's their functional thing. Measure it. Show me what you do at home that you can't do, what position you're in. Get a functional baseline. Always test the shoulder girdle. They're almost always weaker up through here on that side as well. I love testing that prone, the prone T, the prone Y. Look at their trap strength. Look at their rhomboid strength, look at that stuff, because usually that whole shoulder girdle is weaker as well. And whether that led to the issue in the first place, pretty compelling. So again, you're not going to tell them that they have a degenerative tendon, you're just going to highlight their weakness and say that we need to get stronger for you. The other thing which we went through before in previous topics is ultrasound changes don't often marry up to clinical changes. So don't focus on the scan changes. Often they're going to be a lot better even if their scan still says that there's a pathology there. So you'll know if your patient's getting better because their function will improve, their pain will be down, and that pain-free grip strength will improve. You have to continue testing whenever you see them. You want to avoid getting, or you kind of want to educate your patient about better ergonomics. A really big one is an upright mouse, which can be good if your patient's using a standard mouse and they're like that. They're in extension. You want to get them out of that into a neutral position. Upright mice are awesome. So you then might go back and say, okay, well I want you to get one of these. Or if they're on a workers' comp, you would request that from the insurer. Say I want an upright mouse. A lot of women have keyboards that are way too big, so they're ending up like that. So you might get a shorter keyboard. You might end up getting like a little gel pad or something there. That's why you want to ask them, show me what your ergonomics are like. Take a photo of your ergonomics at work. Show me your equipment, show me how you sit. Carrying things with palm up, there's less compression than carrying things like that, and carrying things in close. So think about your force vector, much more out there than it is in close. So, surprise, surprise, we're starting off with isometrics again. They're okay for a little bit of pain. Usually start with a TheraBand. This is a classic exercise, a really good one that's been shown to have great empirical results. So you start them in supination, holding, and then you'll start them in that position. They might go away and do 10 lots of 10 there. Then the next progression is going into pronation. Then the next progression is slowly progressing out there. And that's the longest lever. So that would be your final, and then you can start doing pronation, supination there, back here. That is where I would start every single patient. And you can show them these are your progressions. This is what we're asking you or aiming to get to. So full elbow extension plus or minus pronation, supination. So aiming to get them up to 1 minute holds times 3, that's a lot. That's why we usually, for this one, ask them once, twice a day is probably enough, because compliance to doing that more than that is probably pretty low. Okay. You can use that with a dumbbell as well, but I like the TheraBands a little bit nicer. And then you're going to add your functional movements. So there's heaps here, guys. I would start to add your functional movements once your patient's pain is right down and they can hold out here for that 3 lots of 1 minute with their TheraBand. You can start them off with scap strengthening stuff straight away though. If it's not take go for it, you can do TheraBand loop around their wrist and get them moving into different planes. You can get them prone over a bed doing their T's and their Y's or over a Swiss ball. Strengthen that shoulder girdle if you found deficits and start that straight away. So, cool things you can move into, they can get the hand grippy things from Kmart. The Flex Bar is awesome, so similar to TheraBand colours, it's the same thing, going from yellow up to your blue. You can start to get them doing a twisting, a pulling down, a pulling upwards movement. Order, like you can get your patient to order these or you can order them for your patient, but they're really, really good thing to do because they can feel progression. So usually they'll start off only being able to do maybe 2 or 3. And you say, okay, your goal is to get up to 10 to 15. And they can progress themselves without you being there constantly saying, this is your next progression. Once they're pain-free here, you add in, you can add in the hammer work, you would have seen this one, add in your rows, add in your push-ups if they need to get back to that weight-bearing stuff. Like if they're obsessed with yoga and they want to get back to, you know, downward dog, they need to be able to load through there. So you progress them up to that. Okay, we've got one last one to go. Glute med tendinopathy, I know you guys have touched on this before. Lateral hip pain that spreads down the side of your thigh may present with back and front of hip pain as well. Usually in the over 35s, high prevalence in females. Risk factors, same thing as any other tendinopathy. Overweight, obese, insulin resistance, type 2 diabetes, low physical activity, all of that stuff. So things that are going to flare these patients up, being on their feet all day, walking, running, sitting a lot and lying on the affected side. You know this from tendons. If they've got a high level of night pain and it's painful when they're lying on that affected side, it's pretty likely going to be a tendinopathy. They won't like sitting cross-legged and they won't like doing stairs, particularly a lot of them, depending on their irritability. Ease when they reduce those activities or if they have anti-inflammatories. We'll talk about the night pain stuff. How much do you guys know about this one? You'll see this one a lot. Heaps and heaps and heaps and heaps and heaps. It's a really common presentation. So if your patient's got pain right over that greater trochanter and they can isolate it and they're like, it's here, sometimes it radiates here and a little bit here, you're like, okay. And they've got these other risk factors and they've said, oh, these are the things that I don't like doing and I can't lie on it. It's almost certainly going to be glute med tendinopathy. So You want to palpate over the greater trochanter. You want to time how long they can stand on one leg for before it's hurting. Don't change their biomechanics. So if you get them on one leg and you immediately see a massive Trendelenburg, don't change it yet. You just note down that that motor control and then note down how long. Oh. Does this not happen? No. Closing down. Do not close down. Ah. Sorry guys. Maybe we might be forced. Has everyone got the notes?
Yeah.
Okay. Let's just ignore that. So you've got how long they can stand on one leg. Usually it'll be, if they're really irritable, they're like, oh, straight away, it hurts. External rotation, derotation test we'll do in the tube. Faber test we'll do in the tube as well. They're really simple tests to do. If they've got pain over resisted abduction, so if you get them inside lying and their affected side is on the top and you ask them, you're doing a manual muscle test, take them into a little bit of abduction, push down, get them to resist. They'll usually be super weak or painful or both. So you can do that with a short lever, so with a knee bent or a leg long. A leg long is going to be much harder if you're applying the force down there because it's a longer lever length. So if they're really irritable, bent knee is absolutely fine and you're resisting at the knee and they're pushing into you. So you're looking for weakness and you're looking for pain provocation. Trendelenburg sign, so what's a compensated Trendelenburg versus an uncompensated?
Moving their trunk.
Yeah. So that would be compensated. Yeah. So compensated would be they stand on one leg and they go over, and uncompensated is just that. They just drop on that side. So note that which one it is, and you have to be really looking for it to, as particularly the compensated. So they're kind of, this one's a pretty easy one to differentiate. You've got really clear signs and symptoms, and if you, with these cluster of tests, get a positive for most of them, you can be pretty sure that it's glute medial tendinopathy. I would also test their extension, so their extension hip strength as well. Usually that's a little bit rubbish. So, you've got the notes, look to the next slide. This takes ages to resolve usually. And it takes so long to resolve because it's like the plantar fasciopathy. You can't stop walking. Like walking's a part of everyday life. So avoiding that aggravating activity is often really hard. Same with plantar fasciopathy. The pedometer and the step counter is really good for this one. You may need to offload that patient, in other words, decrease their loading and provide advice and a really good pacing plan around that. Okay, if you're going to go for a walk, you need to limit it to your 15 minutes, no hills, that type of stuff. And then based on symptoms, you can progress up. So a couple of weeks later, we might go to 20 minutes, we might go to 25, etc. So the education on reducing positions of compressions is really, really important. So at night, and we've got a handout at work that we give patients with glute med tendinopathy. Say these are the things you need to be mindful of. Stick this up on the fridge. Pillow between the knees at night, that's to get that leg out of compression. So avoiding sleeping on the affected side, have the affected side facing up, and you're into at least neutral hip or slight abduction. Don't hang off one hip. What we mean by that is don't stand like this, because you're just compressing that tendon. So if your patient's got a sit-to-stand desk, they're like, oh, I thought this would have got better with the sit-to-stand desk. I'll show you how you stand. I'm like, how often do you do this? Oh, all the time. That's a problem. Sitting with one leg crossed, this is a really hard one because you're not even going to know you're doing it, but if you're constantly sitting like that, you've got to avoid that really, really big one. Again, it's just compressing that tendon over the greater trochanter. They may need to limit their sitting to 20 to 30 minutes, and they're not to stretch it. So you'll often have patients come in and they're like, oh, I've stretched it heaps, it's not getting better, stretching is going to make it worse. Remember, a tendon doesn't like stretch, don't stretch. They can spike your ball all around, but not over greater trochanter, not over that tendon. And if they do have other lifestyle-related comorbidities, or they're overweight or obese, you need to bring that up. And that's where you can have your patient information handout, and you can go into that, you can give them that, and then maybe you can follow up at that next session and say, how'd you go? Was there anything that came up for you in that handout? What did you think about the lifestyle stuff? And you can then start to have that conversation about losing some weight and getting fitter. So where we start off, we always start off with isometrics. If you look at your handout, your sideline affected side is on the top. You've got pillows underneath. You're just lightly loading, and you can even go back a little bit into extension so you're not in flexion, and they're going to hold 10 lots of 10. If they can't do 10, do as many as they can to build up, at least twice a day. That's all they're going to do. So start them off with that. Everyone who you see with this, if they go home with one exercise, that's the exercise it's going to be. If they are an office worker, you can get them to push that affected side into a wall or their desk and hold 10 lots of 10 during the day. People aren't going to want to do exercises that are really embarrassing and awkward at work, and that's a really good one. That's no one really needs to know you can do it, or you can, in the bathroom, you can do that one. And then if you look at your next slide, then we can move into your functional stuff. So start off on 2 legs. You're going, a bridge is a really nice one to do. You can have a band around their knees so they're gently pushing out into A abduction. You can go into a double leg squat. You can go into a side plank, because side planks lots of glute med usage. Then you can move into your single leg. Only move into your single leg control if they can control a good squat, a good lunge, and they get it, that their hips are level, their knees tracking their toe. If they're really not great, don't then move them into a single leg squat, because they're not ready for it. If they can't control it, they're just going to be compressing that tendon over the hip, and it's going to make them worse. So they have to be able to control it. I like my patients to be able to get up to doing 20 single leg bridges before I'll move them into the single leg stuff, and for them to be really solid in a lunge. Another nice progression from the intermediate between bilateral loading and single leg loading is your Bulgarian squat, lunge, whatever you want to call it, so leg back up on something behind you. You want to teach them to be able to monitor their hips. If they don't get that that's bad, they're going to be doing that. So make sure that they know how to control, and they know what good control is. If they're losing it through the rest of their kinetic chain and they've got like terrible arch support and their tib post is terrible, that's a factor. Train that as well. So train the whole kinetic chain. Finally, you'll then move up to step-ups. So step-ups and single leg squat stuff is going to be your final strength isotonic training. If they then want to go back into their running, then you would start to move into dynamic movements. So you would have a look at their motor control in landing, so a hopping forward. And if they're still going into valgus and Trendelenburg, teach them and then train them to do a nice dynamic movement with good form. So mirrors can be good for this. Then palpating their hips. They need to know what good control is and what bad control is. It's really, really crucial. This might take a couple of months to go through. Like, it might take 6 months to get someone back to running, and you need to tell them that early so that they don't think, oh my God, I'm not better after a month. Tendinopathies take time. Okay. It's time. It's fast.
11:36, according to my watch.
All right. We won't go through the training concepts stuff, although I would encourage you to look at the YouTube thing on functional training. It's a bit of a piss take with JPCs. I'm not sure if anyone's seen it. It's quite funny. Have a little look at that. kind of goes through this slide, the difference between your